Thanks, everybody. I'm mindful that we're coming to the very last part of what's been an absolutely brilliant day. I'm sure you will concur. You're probably all thinking, who's she? I don't know who she is. I'll tell you in a minute. But it's really great to have you here. I know we're getting dangerously close to wine o'clock, certainly in my book. So I will be very swift. But we've got a very exciting last session, not bigging up myself because I'm doing a presentation on it. But it has been a really brilliant day, and I'm thrilled at just some of the conversations that have gone on, the presentations, how much work is going on in Greater Manchester. We are by far the best at breast cancer, aren't we? Yes, we are, yes, we are, yes, we are. Of course we are. So for those who don't know me, I'm presenting later, but I'm Claire O'Rourke. I'm the Managing Director of Greater Manchester Cancer, the Cancer Alliance, the cancer arm of the ICB here in Greater Manchester. So we've got a session here around the regional and national picture around breast cancer. We've got Kieran presenting, Cleona as well. Kieran is going on an external, so we've got to dial him in, so it's going to be very checking to see that's all going to work. Presenting on the National Breast Cancer Audit. There's going to be a bit of a Q&A as well. So I don't know if we're going to give the nod. Kieran's ready. We all know who Kieran is. Do we need to introduce him?
Afternoon, everybody.
Here he is. Afternoon, Kieran.
How are we all?
Can you see us all? A room full of willing participants?
I can see my slides at the moment, which is really good.
That'll do. That'll do. Crack on, Kieran.
Okay. Hello, everybody. You might think that you really don't deserve on a Friday afternoon to have somebody like me coming to you, chats on audits, and then having two talks. It's more than anybody should have to put up with. So you have all my sympathy. Initially, I'd like to speak to you about the two new national audits of breast cancer. They're going to look at primary breast cancer and metastatic breast cancer, and in comparison to what we were doing before, they will look at all ages and genders. And overall, much like your day today, the aim is to improve breast cancer care. It's a very simple statement, but it encompasses a great deal. There are numerous data sets and national data sets on different aspects of medical care. And you can see them listed down on the left and on the right for Wales. And what we have found with NABCOP previously was it was possible to bring all of these different data sets together who were previously often living in separate silos, but to bring them together at individual patient level. So you could look at the patient, their patient pathway, what treatments they received, the tumor characteristics, and various other outcomes. And that was a huge step forward. The National Audit of Breast Cancer in Older Patients, which I hope you were aware of, was set up back in 2016, and it evaluated the care of women diagnosed in NHS hospitals within England and Wales aged 70 and over. And then for a comparison group, it looked at all 50 to 69-year-olds. So it included greater than 70% of all breast cancers. And to give you an idea, with these large national audits, what kind of numbers we're looking at. If you look at this table, and you can see, for example, highlighted the number of women aged 50 to 69 in that audit was 102,000. So we are talking a large numbers, and therefore you get a great deal more confidence in the statements that you can make. And all types of things turn up at times that you think, well, I would know that. I was surprised to see that 34% of women aged 70 to 79 had their cancer diagnosed through screening. And we can see for the metastatic group that in the 80-plus-year-old, 12% of those come through as an emergency, which is a very unusual route for a breast cancer diagnosis at all other ages. So large numbers of patients. And one of the things that we'd often been told as we were coming through in training and a bit later was that breast cancer in the older patient was more indolent. When you look at the figures here, you can see that the percent of high-grade cancers didn't really change much across the age groupings. And when you look at what type of cancer. You can see that things like the molecular results, such as estrogen receptor positivity, again, were pretty much identical across the age groups. So by and large, in the age groups we were looking at of more than 50, it was the same breast cancer. It isn't more indolent, it isn't more easy as such to ignore and let be, and it will never cause trouble. So audits can show that type of hard information compared to single cohorts from individual institutions. And when we looked early on at the receipt of breast cancer for women who, according to their ER status, and we're looking at these, excuse me, the age groupings across on the x-axis and the ER positivity, I beg your pardon. And we can see on the graph on the left, you're looking at the white boxes, and the white boxes are showing you the numbers of patients or percents of patients who don't receive an operation. And that increases quite markedly, probably from around the mid-70s. Whereas on the graph on the right, you can see with ER negative, the white boxes really don't appear until the patients are very old. Now, you could say that obviously patients with an ER negative cancer are much fitter than patients with ER positive, but that wouldn't hold up for very long. It's obviously a difference in approach, a difference in the way they are cared once there's an option. And then we looked to see, was it all due to fitness? Because people would say, as people get older, it's obviously the changes were made because of fitness. And we devised an index that would give a very good approximation of fitness and frailty called the SCARF index. And you could see that the tail off in breast surgery in the ER positive in the gray graphs happens whether you are fit, mildly unfit, or severely unfit. So it's a reaction to the age rather than to the fitness of the patient. And then during COVID, you can see that what was standard as regards radiotherapy that we're all familiar with, the 3 weeks of radiotherapy, which was traditional for years. In early 2020, many different circumstances came together. Trials came and showed an evidence base that a shorter duration of 15 fractions over 5 days had equivalent outcomes to the previous 26 Gray over 3 weeks. And the other way around, the 40 Gray over 3 weeks, 26 Gray over 5 fractions was equivalent, which is shown by the dark bars. And because everybody was keen, to keep people out of hospital, it was accepted and introduced within weeks. And you can see the difference in what was done as regards standard radiotherapy practice happened from March 2020 and was almost achieved by April 2020. So it does show that as clinicians, we can be open to change if the circumstances are right and if it's possible to get through the system and all of the different permissions that one needs. When we looked at metastatic breast cancer, we are quite confined about the groupings that we can see. When we looked at all of those patients at the time of their first diagnosis, we saw that about 5% were said to have metastatic breast cancer at the time of first diagnosis. And when we tried to look at recurrence, which I would ask for your assistance in, the data on recurrence nationally is very poor. You can see here that 22% of women who died of breast cancer had a record of recurrence. A great deal more had recurrence, but it was never recorded. And we're looking at recurrence recording of only about 4% of patients. So we all could do a great deal better. And my understanding of what happens is that most patients are now discussed at MDTs at the time of recurrence. But if you can take away a message from today, that when they are discussed at your MDT, your MDT coordinator or whoever's taking charge needs to open a new non-primary breast cancer diagnosis pathway. And that must be accompanied by a date of diagnosis of the recurrence. And then your recurrence return from your trust will improve greatly. If you don't do those two things, then you will continue to show very poor returns nationally as regards recurrence. Auditing metastatic breast cancer is a whole new area, and of interest, no other tumour group have been asked to do this. And many different challenges appear. We have in metastatic breast cancer patients who are diagnosed with metastatic disease at the time of first diagnosis of any breast cancer, and then those patients who have who are known to have a previous breast cancer and who later have appeared with metastatic disease. The second group are particularly difficult to find information on. You can see on top we have the primary breast cancer, and then later we see local or distant or both. And then we have the metastatic breast cancer at the time of first diagnosis. So both of these cohorts will be looked at as part of the new audit on metastatic breast cancer. We did a large scoping survey. We wrote to everybody a few times. You probably noticed in your email in-tray. And we asked what were the issues that you thought needed looking at that were most likely to give benefit to patients if problems were solved. And the feedback told us we should be looking particularly at triple negative breast cancer, younger patients and older patients, and that male patients, a great deal remains unknown. And then there were a whole range of other issues in the feedback as well to do with staffing, which I won't go into today, which you're all very well aware of. So thank you for your attention for that whistle-stop tour. We were keen at every stage not to add to your workload. So what we want you to do is to return, as you would normally, into your COSD, those usual items that you should return, but please also do your best as regards recurrence. Open the new non-primary breast cancer diagnosis pathway, and please put a date of diagnosis with it. You can choose what that date is, be it the date of the scan that made the diagnosis of recurrence, the date they were seen, the date of the MDT. It doesn't matter, but you won't go forward as regards a date of return unless that date is included. Thank you very much.
Thanks, Kieran. And you're going on next to your girth work, is that right?
Do we want a break in the middle of that?
I'm quite happy for you to carry on, then we'll do some questions after, if that's okay.
Okay, let me... Have I transferred on your screen?
Yep, you have. Brilliant.
Isn't it marvellous what happens?
Tell you what.
So, NABCOP, that's the source of the data for the following talk that I'm going to give to you about reoperation. And again, it was established in 2016. As we said in the last talk, the care of women over 70 was the prime target, but 50 to 69-year-olds looked at as well. So we're looking at more than 70% of all breast cancers. And the thing that's most important, particularly in the surgical community, about what we offer for patients is the cornerstone is satisfactory breast conservation surgery. We can do many other things as well, but if we're not doing this well, we're not serving the patient population as well as we could. So if I start taking you through some of these slides. bear with me. Along the x-axis, you can see all the individual NHS trusts. And on the y-axis, the percentage of women. And in the pink line, you can see the percent of patients in each trust who had breast conservation surgery. And that in itself could be a talk for a different day, because the variation in the percent of patients in each unit who receive breast conservation surgery, as you see, is quite marked. Then along the bottom, in the wavy dark blue line, you can see the reoperation rate. So it's looking at patients who had breast conservation surgery for early invasive breast cancer, that's T1 to T3, who had a subsequent breast operation within 3 months. And we purposely excluded the first 7 days where they may have gone back for hematomas or bleeding or some such. So if you look on the y-axis, you can see in and around the 20%, and the reoperation rate is between 10 and 20. And there's significant variation between the different trusts. And for the Manchester Alliance, we tried to look individually, and your reoperation rates are in the green outlines. I hope you can see those, that they transfer. So that's the reoperation rate for the Manchester Alliance trusts in the overall. And you vary much like the overall graph varies. So there's a reoperation rate of an average of about 13%. Somewhere between 1 in 7 and 1 in 8 patients are going back to have further surgery after their first operation. Looking at a similar graph, and we're looking this time at DCIS. And if I can bring your attention to the y-axis. Oh, sorry. Okay. Bring your attention to the y-axis, where we were looking at 20% before. You can see that most of the points lie above the 20%, and many are at 40, and some are at considerably higher. So the reoperation rate for DCIS is substantial by anybody's estimate. And again, in green, you can see the figures for the Manchester Alliance trusts. Stuck at the moment. Wonderful. When we then try and look at, does this change? Because we all like to think we're getting much better over time. And if you look along the x-axis, both for DCIS and for early invasive breast cancer, we show minimal change over the 5 years worth of patient information that we had in the audit. So looking, for example, on the early invasive breast cancer, you can see that we were a little bit more than the 10%, 14% to be accurate in 2014, and we came to 12% in 2019. So hardly any change, and even smaller amounts of change in DCIS. So there is no improvement in this reoperation rate, which is disappointing. Here we're looking at reoperation rates, and we're going to look at these in different ways to see if it tells us more about what's happening. When we look at the reoperation rate, and we can see the numbers of patients involved, most patients that we see have small tumours less than 2 centimetres. despite that fact that this is a large volume activity, we still end up bringing almost 11% of patients back for a repeat operation. If I asked in the room, people would say that's really unlikely. It's usually bigger tumours. I'm afraid that's not the case. And then various other aspects, including nodes, slightly higher as it is more metastatic to nodes. And then we'll break up later on as well, looking at what we call the risk of the tumour, whether it's low, intermediate or high, with the combination of tumour and nodes. But whichever way you break it down, if you look at the column on the right, the percentage reoperation rate is substantial. And when you look at 5 centimeters plus, that's T3 tumours, we're looking at a 40% rate of reoperation. So looking at the funnel plots, and all the dots represent a unit, the Welsh data didn't quite correlate and match up with the data we had from England, so they will appear as outliers, good or bad, in different ways, and they are in the red dots, so please disregard that. You can see in the green dots the Manchester Alliance trusts, and along the x-axis you're looking at the numbers of patients treated in that unit over the length and duration of the trust of the audit. So for smaller tumours, there's a great deal of clustering, but there isn't a great deal of decrease below the 10% mark. Then we start to see more of a scatter as we go from 2 to 5 centimeters, and you can see a lot more trusts are 20, 25 and 30% reoperation rates. And the large tumours, there weren't sufficient numbers to put the Manchester Alliance data on this without losing the anonymity of what was happening. So you don't see your green dots on this graph. But if you look at the y-axis, you can see that the bar has gone to 40%. And there are some units with very high rates of reoperation where any independent person would say this needs a serious look at. It would be hard to justify having a procedure where you knew within your unit you had that level of reoperation return. DCIS, we're looking where the bar is at roughly the mid-20s, 24%, and then quite a scatter, 30% not being uncommon, and even higher. You can see the Manchester figures in green. I mentioned earlier, we tried to look at cancers as regards to low risk. So here you're looking at small tumours that were node negative, and they are clustered as regards, there aren't too many major outliers, such as over 20%, but 10% is more the norm. And then you get into those middle ranking tumours with some degree of nodal positivity, and you can see the spread as it happens. And then high risk, and we had enough figures here to show the Manchester data as well for a number of the units, and you can see there is quite a spread. So my guess is if you as an alliance decide to look at this, you're going to see quite a spread across your different units. So in summary, reoperation rates after breast conserving surgery are substantial. There has been no significant decrease seen over time. There is wide variation in the reoperation rate between units. Reoperation rates are particularly high and large variation when you're looking at larger tumours. But the high volume operation that everybody in this room is aware of, T1 tumours, the reoperation rate is still approximately 10%. I think this needs addressing. I think you need to know as a particular breast unit what your reoperation rate is. And as an alliance, you need to, at the next perhaps meeting, be able to ask all of the different trusts to show what they have found when they have audited reoperation and tips and various beneficial aspects that they've discovered by doing that audit. Thanks for your attention.
Kieran, thanks very much. And I didn't introduce myself. I'm Claire O'Rourke, chairing this session, the Managing Director of the Cancer Alliance. Lovely. Are you over in the Emerald Isle? I didn't know where you were with that accent.
I have it from birth.
You do, of course. Right, there is going to be some brief questions, if that's all right. If we can manage to orchestrate some questions. And there's a few hands going up. You're very popular, Kieran.
They're trying to get out, Claire.
Well, I'm on next, so I can understand why.
Hi, Kieran. I'm just wondering what the reoperation rates that you've got there, does it differentiate between going back into the axilla versus going back into the breast? Because in Manchester, we manage the axilla very surgically, should we put it that way, compared to other centres around the country. And so that might skew our data a bit if it can't be differentiated.
This data is for breast reoperations.
Perfect, thanks.
Oh, yeah.
Hi Kieran, it's Claire Curran. Just wanted to ask if you had any insight into whether reoperation rates are driven by involved margins and them needing a reoperation, or could it be more rigorous or aggressive MDT decision making where they're less accepting of small margins, as in how much of it is about the surgery and how much of it is about the decision making post surgery?
Hi, Fiona. That's a really good question. Again, it's hard to break down because we don't have data as such that says this is the reason or the decision for the decision to reoperate. We don't record the decision on any of the national data. But looking at various aspects and trying to look at units who accept, as long as not on the ink, or units that wish to have, for example, a millimeter, I don't think there's a great deal of difference. And I'm inclined to think as well that it's not due to those aspects of hawkish MDTs or less hawkish, because when you look at the reoperation rate for T1 tumours, it's difficult to think that they can't be removed with at least a millimeter clearance, and that if you took away that 1 millimeter to allow people to say they had removed it, as long as the ink wasn't involved, that the surgery that had been performed was any more clear cut. So I think there's more going on than that, and one would have a concern that this is surgery that's not being done well.
Hello, Professor Horgan. It's Claire Garnsey here. Thank you so much for joining us today. If you don't mind, I've got one comment and then a question for you. The comment is just to the room for awareness that we're expecting some information from one of our colleagues, Tracy Irvine, whom many of you will know. She leads our GIRFT programme, and she was telling me yesterday that we're expecting to have some information about the data that the national team, that Professor Horgan and Tracy want us to collect, and that should be end of November. So if you're gearing up to do your audits, hold fire, and we will get some information to you, hopefully early December, so that we're all collecting the same data on this, because I think we can see from what Professor Horgan has presented to us today that there's a real need to understand this huge variation. The question I had, Kieran, is just about when we're looking at, you showed us that very strong data that tumours over 5 centimetres have this very high re-excision rate, of 40-odd%, which I don't think we're consenting patients for. But is the assumption correct that 5 centimetres was taken from the post-operative specimen and therefore might not be the fact that we know it's 5 centimetres and then can preempt that higher re-excision rate because it's actually that the tumour is radiographically occult?
Yeah, very good question. And the initial comment, I suppose the only comment I would add to that is that please don't wait. Please don't wait to put things together as regards looking at this information. It is good to have a steer to try and do the same thing and know the definitions and so forth. But please, from today, go about thinking that you will go and look at this information, that you need to know what you as individual surgeons have as reoperation rates and what your unit does, and then you can break it down as to why you think those decisions were made. The data that we have is almost all pathology tumor size, as you say, because that's what we usually use as our TNM. So it would be based on that. Whether that's then means that tumours that were unexpectedly large account for some of that higher reoperation rate, I'm sure that's the case, but I'm also fairly certain that quite a bit of it is not due to that reason.
Brilliant. Kieran, thank you so much for your time today. We welcome both those presentations, but particularly I think some of the work around the audits on metastatic cancer that we've never had a national view on, and particularly a lot of our patient groups here welcome that. So brilliant work, and your ask around re-excision rates and looking into that, that's an ask that we will take back as a Cancer Alliance, as we've alluded to. So many thanks for your time, and it worked virtually. We're doing a big whoop. Thank you for your time.
Thank you. And if I could again make one repeated ask, document the recurrence at your MDT.
Yeah.
Set up the new non-primary diagnosis pathway and put a date to it. We would all benefit greatly. Thank you so much.
Thanks, Kieran. Thank you. So, Claire, you're coming up next for your research trials. Right.
Hi, I'm Claire Curran. I'm one of the breast surgeons at Wythenshawe, and I'm going to talk today about breast cancer research. I'm going to talk about it from a Manchester point of view and also from a national point of view. So Claire highlighted that Manchester is the best, and clearly that's true. So I just thought I'd do a little bit of a recap of how awesome Manchester is, starting with Edith Patterson. Now, she was a bit of an awesome lady who was a radiobiologist who did an awful lot of research into stilbestrol and phenylephrine as early tamoxifen-type drugs, and actually did some really important clinical trials at the Christie Hospital. Her husband, Ralston Patterson, did research into ovarian radiotherapy and impacts on breast cancer, because they were beginning to get a feel in that sort of era that estrogen was driving a lot of breast cancers. And I don't know if you all remember the Patterson Institute that conveniently burnt down about 5 years ago and got it replaced with a fantastic building. Thank you. It was named after these two. Now, Arthur Walpole was a fantastic scientist based at ICI in Alderley Edge, which is now AstraZeneca, and he did amazing research on what effectively was tamoxifen, and he led the ICI fertility control program, and part of his research was demonstrating that tamoxifen was a fantastic post-coital contraceptive in rats that were regretting their behaviours. But unfortunately, in humans, tamoxifen actually seemed to stimulate ovulation rather than inhibit it. So it wasn't a fertility treatment in humans. But again, at 60s, much more awareness of the role of estrogen in breast cancer. And he had the idea and did some basic research on whether tamoxifen had the potential to be an anti-cancer drug rather than a fertility drug. So he worked with Moya Cole, who was, again, another radio-oncologist at the Christie, and they ran the first clinical trial in tamoxifen. They recruited 46 women with metastatic breast cancer and demonstrated a really fantastic result in 10 of those women. And so that was the first trial of tamoxifen, and it was done at the Christie, so whoop whoop. And Moya went on to found the St Anne Hospice, so she's a woman with real mojo. Now, if we move a bit more to recent times, some of the major game players are Tony Howell, who we all know really well, who's led the trials in tamoxifen as a prevention drug and then anastrozole as a prevention drug. And obviously that is a major game changer in breast cancer. And then we've got Gareth Evans, whose work's been mentioned numerous times today, but including the work from PROCAS that has allowed us to work out which women are higher risk versus which women are lower risk, which ultimately will allow us to tailor the NHS breast screening programme so that we're not all getting the same, and it's going to be hopefully much more personalised and efficient. Within Manchester now, we have the Manchester Breast Centre, which is a centre where we have clinical, translational and basic scientists working together. And it's probably one of the biggest breast centres doing research in the whole world. We have over 100 scientists working in this virtual centre, from people looking at cell lines in normal breast to clinicians, faces you may recognise, to psychologists, to physicists looking at AI in imaging. So a complete mix of scientists but doing very much leading research. We also have an awesome biobank with a huge number of specimens, fresh and frozen specimens, that can be really game-changing in terms of the type of research we do, because obviously any research done on actual specimens rather than cell lines is way more valuable. And we have the Prevent Breast Cancer charity, which is the only breast cancer charity dedicated to prevention, and funds a lot of important research, including a lot of Gareth's research, but also now is helping fund the National Breast Imaging Academy, which will be a new build added on to Wythenshawe Hospital with the aim of training a whole new group of radiologists and radiographers, and with the idea of upskilling people so that people who were healthcare assistants become radiographers, the radiographers become consultant radiographers, and the radiologists, we don't need so many of them. And this is a national project that will benefit the whole of the UK, but also will provide educational services worldwide. So yeah, Manchester's great. Now, I'm going to talk a bit more about the national sort of arena for research, and just a few key trials that are open in the UK, and a plea to please support these trials. If they're not open in your centres, please fight to get them open, because the ones I'm talking about, they still want to open more centres. And if they are open in your centres, then please, they are massively important trials, so everyone needs to be on board with them so that they are mentioned to patients at the very moment that it becomes relevant to them. Okay, so I think Probably one of the themes that is coming through in a lot of clinical trials in breast cancer at the moment is that of de-escalation, where we have achieved so much in terms of survival benefit, but now we need to de-escalate treatment so that we're not causing unnecessary side effects and allowing us to tailor our treatments more specifically so that we're not over-treating people. So one of the trials open is the SMALL trial. So that is looking at small tumours that are grade 1, so your nice, fluffy, tiny ER-positive breast cancers, and actually is surgery unnecessary for these? Or do we really need to do a wide local excision and sentinel node biopsy, or actually can we vacuum these tiny cancers out? And so this is open at several centres. They're already recruited 339 of the 800 patients they need, and it's randomising women on a 1-to-2 basis to either wide local and sentinel node or to vacuum assisted excision of the cancer. And if that fails, as in you can still see a bit of the cancer on imaging, they go on to have formal surgery. But if it looks radiologically successful, then they'll just go on to having their radiotherapy and then their mammograms. And actually, I've recruited patients to this, and there are a certain cohort of patients who really do not want surgery, and this is their nirvana. So it is a really important trial, and it's surprising you can't tell until you have the conversation which patients are going to love this and which patients are going to hate it. So it's a great trial to mention to people. The ENDONET trial is one that's only just opening, and the fundamental question in this one is, should we be using neoadjuvant endocrine therapy in the same way that we sometimes use neoadjuvant chemotherapy? And there's a great variation across the country. So, you know, in Scotland, they're very keen on using primary endocrine therapy to shrink tumours down, and we probably use it less. Certainly in Wythenshawe, we tend to use it less. And who is right? So this research question is randomising patients who have tumours. It says over 2 centimetres. It's now over 1.5 centimetres. So anyone who has a ER positive, HER2 negative, node negative tumour, small tumour, well, not tiny tumour, but above 15 millimetres, randomising them to either standard of care, which would be surgery, or to up to 6 months of endocrine therapy to try and shrink the tumour down, with the primary endpoints being, can we increase the rates of breast conservation? So, you know, those cancers that are 4 centimetres in a small boob, that would be a mastectomy. Can we shrink those down and have increase the rates of breast conservation? Is there an impact on nodal surgery? If you are, we're always going to do breast conserving surgery. Can you do prettier breast conserving surgery? So is there greater patient satisfaction? So it's about what is the impact on tumour size, on breast conservation rates, and on quality of life are the primary endpoints for that study. So again, a very important study, because we're all thinking, oh, it's a bit big and it's a nice cancer except for the size of it compared to your boob. And actually, is this safe or isn't it? We want to know. ATNEC has been open for a while. Now, this is in women who are node positive at diagnosis and are going on to have neoadjuvant chemotherapy and then get converted to node negative on imaging. So they were node positive, become node negative because of the chemotherapy. And what this is if they are node negative after chemotherapy and surgery, are we over-treating them by doing clearances because they were node positive, or can we do less to the armpit? So the plan of this one is anyone who has a lowish volume node positive cancer, you have the node clit that is positive, you have your neoadjuvant chemotherapy, you have your imaging. If imaging says you look like you're node negative, then you go on to have your breast surgery and a sentinel node, not the clearance that we'd have done in the olden days. If the sentinel node comes back as negative, then at that point you get randomised to further auxiliary treatment like we'd have done in the olden days, and most ladies are having radiotherapy, or no further treatment. And ATNEC is recruiting, he just sent me the numbers. But I think that it's doing well. It's still in the relatively early days. I think they're at about 150 or 200 or something like that. But they're now looking at adding in an extra arm. So this is hot off the press. But they're now looking at those patients that don't convert to node negative, but appear to have a low volume node positivity. So maybe they only have 1 or 2 nodes left, and you potentially could have got them out with your sentinel node. Can they then get away with less treatment? So they're getting randomized to radiotherapy or clearance. So that bit of it isn't open. But again, we are all desperate to de-escalate the axilla because lymphedema is hideous. So these, again, are really important trials. Optima, and Rob's gone, but Rob's leading on the Optima trial. And this is, we still need more data about the roles of genomic testing to guide chemotherapy. So this is a study looking at the Prosigna test rather than the Oncotype test. And it's taking women who are node positive or large tumours, so a group where you would classically have given them chemotherapy, and instead of giving them chemotherapy, they're getting randomised to standard of care, which would be chemotherapy, or to chemotherapy decision-making being guided by the Prosigna tool. So half of them will get the Prosigna test, and then if it says you're high risk, you get the chemo, and if it says you're low risk, you don't get the chemo. So in other words, a subgroup of these will avoid chemotherapy, and is the survival outcomes the same? And they need 4,500, and they've only got 910 to go. So we're getting there with that one. But again, the way to help with these ones is when you see a patient who go off and have that chemotherapy discussion, as surgeons or as the sort of pre-chemotherapy team, please say to them, you may need chemotherapy, not you will need chemotherapy. Because in any clinical trial, once you say you need something, it's very hard to take it away. So if the radiologists for the small trial say you need surgery, then it's very hard to de-escalate that to, or would you like a vacuum excision? So just be aware of the trials that are available and don't sort of close a patient's mind by telling them they need something when there are actually other options. Another systemic de-escalation trial is HER2 radical. So we routinely give a year of Herceptin, but in those patients that get a pathological complete response with neoadjuvant chemotherapy and Herceptin, are we actually over-treating them? They've got very sensitive tumours. Do they really need all of that Herceptin? So this is actually, it's not a randomised trial, it's a study looking at those that get complete pathological response at surgery and de-escalating the trastuzumab. So again, a trial where we need to be flagging to the patients, you may not need a whole year of Herceptin. The oncologist will talk to you about trials, you know, so that it's easier to get them into this trial. And recruitment for this, because this is relatively newly open, they're now up to 53. That's today's data. Okay, so the Poetic trial is a really important trial, and it's led to the Poetic A trial. So just to set the scene, the Poetic trial gave women 2 weeks of aromatase inhibitors prior to surgery. It looked at their Ki67 at diagnosis and their Ki67 at surgery. Women who have a low Ki67 at diagnosis have an excellent outcome. Women who have a high Ki67, and it was over 10% for this, and converted to low with endocrine therapy also do brilliant. But women who have a high Ki67, have a fortnight of endocrine therapy, and still have a high Ki67 at surgery, have a much worse outcome, and that's the green line. So what can we do to stop these women getting recurrences? And the Poetic A is picking out these ladies, so they get their 2 weeks of endocrine therapy. If they've still got a high Ki67 at surgery, then they are randomised to standard of care, which would be endocrine therapy, or, because they are higher risk, chuck in the abemaciclib as well. So this was designed before abemaciclib got licensed, and we had suddenly abemaciclib is available to people. But actually, if you look at the criteria for giving abemaciclib, because the criteria and the trial for abemaciclib, the monarchy, was done on such higher risk groups, so women who were node positive, 4 nodes, larger tumours, actually, the Poetic A trial of high Ki-67 will allow way more women to access abemaciclib than the pathology tumour nodal staging that we currently are using in NICE guidelines. So it may be, I mean, abemaciclib we've already discussed, and Suzanne's explained it to us, is a fantastic game-changing drug, but we're giving it to a small number of women. Now, don't shoot me, oncologists, but we may be able to give it to more women. I know you're only a little bit overworked, and so the Poetic Hay study will help us find out whether we should be giving it to more. Okay, and then we've got the Parable study, which is a really cool study because it's using the proton beam, so that's why it's Manchester's brilliant as well. And this is randomising women who have internal mammary nodes positive and need internal mammary node radiotherapy to either old-fashioned photon that you can give everywhere, or proton beam that you can only give in Manchester, or eventually London got round to giving it. So again, a really important study, and we're up to 45 of 192 recruited. So my message is, please get involved in research because it gives better care and outcomes. As Kat was highlighting, you know, if you have access to research, then patients can do better. They do better even when they get the standard of care arm. It improves future practice. It allows us to move on. Like we're all marking nodes now because of APNIC and POSNOC. It educates the trainees, it brings in money, supports infrastructure, and patients want it. Thank you.
How brilliant. Really, really amazing work going on there. And we all know that the benefits of all those treatments and the surgeries we've done are all because we did it in a trial and it was beneficial, and we've absolutely got to advocate for more trials. Has anyone got any questions for Cleona? Or should we crack on? Because you were so amazing. No one's got any questions. Do I just click that? Oh, bugger, it's me. Oh, yes, okay. I'm going to give a very brief update on what the national priorities are for cancer and what the role of the Cancer Alliance is, because I've worked at the Cancer Alliance for 7 years now. I still meet people every day who don't know what they are, and I'm presuming there's a lot. Anyone in the room tell me what a Cancer Alliance is? Anyone put their hand up if they don't know what a Cancer Alliance is? Oh, well, I'm preaching to the converted. Thank you, ladies, and thanks to everybody who's contributed. I'll just leave now. No, joking aside, I've been in cancer services my entire career, and I started at the Christie in 2001, hence the grey hairs, as a baby nurse in palliative care, and then I went into breast cancer and breast cancer research, so it's a massive love badge for me. I'm not nursing anymore. I went to the dark side and went into management, but I'll come on to that later. My greatest moment was actually working with our esteemed colleagues here on the HERA study, and actually that study with Herceptin changed my life and made me realise that lock and key mechanisms of that marvellous drug, you can change, you can do massive, and that study happened like that. We got people on it, the treatment. I can't tell you how amazed it was. It was the single greatest moment in my nursing career, and that instilled a little something in Claire O'Rourke to think about how you can change things. So that's why I'm now working at the Cancer Alliance, and I'm hugely thrilled to be here today with you all. What does the Cancer Alliance, what's our aims? Well, everybody in this room wants to make cancer patients diagnosed earlier, and when you are diagnosed that you live a very long time. And your slide that you put up before, back in the 60s, and we all know what people's chances of surviving cancer was back then. We've made such improvements. Today's been celebrating all the great work that's going on, but we've still got a long way to go. And indeed, out of that 55,000 patients, it equates to just under 3,000 in Greater Manchester. But, you know, we want to increase the survival of our cancer patients in breast cancer, but across the board in all our tumour groups. And how we're doing in Greater Manchester. Now, those who've been on a train recently, I know Claire came up from London, the north-south divide is forever evident in some of these slides that I put up here. As you can see in Greater Manchester, our early diagnosis figure, remember we've got to get to 75% by 2028. We're at 59 at the moment. The national average is 56, sorry, the national average is 58. So we're doing well. But as you can just see how far we've got to go on early diagnosis. We have turned the dial in the last 5 years, despite COVID, despite what's gone on. And actually, COVID has probably helped in some of the slides we've just seen accelerate some of the work that we need to get done. So there's a significant amount of improvement made. Early diagnosis in primary breast cancer. As you can see, for us here in Greater Manchester, we're at about 81%, and the national average is at 86%. So although in breast cancer we're doing really well, I can assure you in our other tumour groups we are nowhere near that. So our early diagnosis is so important to get done for our cancer patients. And what are the things that we're looking at as a Cancer Alliance? Well, one of the reasons I came to the Cancer Alliance and one of the reasons I'm in senior management roles is it's really important to listen to clinicians. There's nothing that anybody said here today that hasn't come from an idea from a clinician or a nurse or an AHP who works in clinics. And what we do at a Cancer Alliance, you come to us with a problem and we empower you to be able to make the changes needed across your services. And it's really important we don't just look at as a Cancer Alliance, your provider, so the Christie and MFT, we won't make the scale of change we need on that early diagnosis and turn the dial on it if we don't look across the system. It has to be system change and system impact. So we have a long-term plan which we have to deliver, and we're working with our systems across Greater Manchester. But it's important that we don't do things in isolation. There's been too much silo working, but COVID almost brought us out of the shackles of that, which was great. So the things that, as a Cancer Alliance, that we want to do, the integration word is really key because we are representing the system here in Greater Manchester, as I've alluded to. I've talked about early diagnosis and improving survival. Improving patient experience is really key. Sasha and others talked before that patients are living longer with cancer, we're getting more treatment options. That's really good, but are you living well when you have that cancer? We talked before about toxicities, and all the drugs that we're giving are making patients have more toxicities. Is that really the quality of life that we want to give some of our patients? So it's how do we marry that up? Health inequalities is a massive problem for us here in Greater Manchester, and we are brilliant and we're doing really well. We're 40 out of 42 most deprived. Everyone knows that because we live here. But at the moment, I bet there's a patient today who's been told that they've got cancer, but has to make the choice between going for the cancer treatment or feeding the children or, not being able to afford to get the bus. That's the reality of this poverty issue we've got here in Greater Manchester. So we do need to target our therapies, target our services and target what we give to our patients to those of greatest need. And health inequality is a massive part of the work that we do as a Cancer Alliance. Speeding up cancer pathways, massive bugbear of mine. 62 days, no. I think we all accept that we make our cancer patients wait far too long. My husband got diagnosed with cancer a couple of years ago. He didn't wait 62 days, probably because of my influence and been able to get him seen and diagnosed quicker, but that's unacceptable because I know other people wait far too long. We do all right in breast cancer, actually, but in some of our other tumour groups, head and neck, colorectal, patients are waiting far too long. Indeed, in lung cancer and others, patients are metastatic by the time we get them through the treatment pathway. So speeding up our cancer pathways is a critical part of the work that we do as a Cancer Alliance. And promoting this personalised care. We've talked about all these targeted treatments. We do need to personalise what we do, whether it's your genomics, whether it's the treatment options, whether it's the trials that you're offered. And that person-centred care, it sounds a bit twee, but it's really important that we look at cancer patients as individuals. And this event today has been brought together by our brilliant cancer workforce team and our cancer education programme. We need to look at our cancer workforce. I don't suppose anybody in this room is surplus of staff, feels like they're not overworked or can't really see the wood for the trees, and you might be retiring or you might be leaving to go to a new job and you're worried about that succession plan. we really need to focus on our workforce, and I don't really particularly care that Elon Musk thinks that we're all going to be treated by robots in the future, which I know that he's been having lots of conference on. I don't mind him looking at a scan or him looking at my genomic profile, but I don't want to be told I've got cancer by a robot. I know that we're a long way off that, but the AI initiatives and some of the things that we're doing in the future will help. But really, we need to look at our workforce and strengthen how we educate our workforce, how we succession plan. It's absolutely critical, and we haven't particularly in any organisation done that very well. So the Cancer Workforce team at the Cancer Alliance and the Cancer Academy are looking at how we manage that, and it's really important. So if you want to know what we do things on one page at the Cancer Alliance, plan on a page, we call it. And you can't see it on this slide terribly well, but you can access our planner page, which describes what we're doing as a Cancer Alliance. So we are doing from prevention to early diagnosis to treatment, acceleration of your pathways, as I've alluded to, but also support for secondary patients who have METs, secondary breast cancer, and patients who are in palliative and end-of-life care. So it's the whole pathway, underpinning strategies around workforce as well, and research and education. So that's our planner page. Please do come and have a look at it. So our governance structure is really important because we don't, as the Cancer Alliance, we're very fortunate we get money. Keep quiet about that. Don't tell anyone we get any money because everyone will be coming to us for money. But we get national funding to do the work that we do. And we have very specific programme boards and very specific pathway boards, of which many of you are members of the Breast Cancer Board. But they're not just meetings where you sit around and we have nice discussions and you get coffee at the end. We need to make sure these programmes of work are delivering, and each of these programmes of work, whether it's health inequalities, whether it's our targeted lung health check programme, these are driving through delivery and change in the system, and I hope you're all involved in some of these programmes of work that's listed there. Our pathway boards are critical to me. When I came to the Cancer Alliance 7 years ago, we had pathway boards. I thought it was a great idea. Some people said we had too many. There was some of the smaller tumours didn't necessarily need a pathway board. My message, the message from the cancer, every cancer patient matters. Whether you've got a child with a brain tumour or a neuroendocrine tumour or advanced colorectal tumour, we should have a clinician, a manager, patients and the system representing you to make your cancer journey better, cancer experience better, cancer pathway better. So we have stuck, despite not everybody in the UK doing this, pathway boards that represent every tumour group. Of course, the breast pathway board is by far the best, as you all know. Slight bias there, but that's important that we are representing every tumour and every cancer patient matters. So that bit of money that I get every year, we get as the Cancer Alliance, we have to assure Greater Manchester that we're spending the money correctly and that we're delivering. That's really key. We do it through an assurance. We have a cancer board that we bring all our programmes of work and that delivery and that financial envelope. Then we feed into the GMICB as well through these various routes. I'm managed, owned, whichever way you want to look at it, by NHS England. So we work on behalf of NHS England, so the NHS National Cancer Programme, and also the regional team. So there's lots of ways that we report in all the work that we're doing, which is really important. So our plan's pretty clear. We need to make sure that cancer patients and cancer services are prioritised. And this has certainly happened during COVID. You will have all seen that lots of patients who had cancer were prioritised during COVID, thank God, which is really important. And ensuring that we're working with colleagues who work in elective services. Supporting innovation, to me, is the single biggest, most important thing that you can do as a Cancer Alliance. So if you are a nurse or an AHP or a surgeon sat here today, and you have an idea about how you can make improvements to cancer services, we want to listen to you. And we have listened to people in the past. So there's a couple of big programmes that we've done in the Cancer Alliance. So targeted lung health checks. You all know targeted lung health checks, which is an early screening programme. It has caused a stage shift in lung cancer diagnosis. That happened because the clinicians were sick of every patient coming to clinic stage 4. So it was a clinician saying, we need to come up with this programme. Yes, they did all the work, but they got national funding and it's now a national exemplar. Our Cure Smoking programme, which some of you may or may not have heard of, how bad is it when you walk past the Christie and you see cancer patients outside smoking, not always with chemo up, but sometimes, and it drives me mad. It probably drives everyone mad. When you're an inpatient, you need to be able you're at a vulnerable moment, and we've set up this programme called Cure that encourages cancer patients to quit smoking. That was Matt Everson here, who just said he couldn't believe why we didn't have a smoking therapy for patients. And that's the Cure programme that's now been took on by the national team. A Prehab for Cancer programme, so you may have heard our Prehab programme. We had an anaesthetist who come to us, the Cancer Alliance, said, I'm sick of my cancer patients coming for surgery and they're not fit enough. They're not fit enough, they're not well enough, and then they have surgery and they're in too long and they don't recover. So he set up with a team, with our team at the Cancer Alliance, the Prehab programme, which gives patients exercise, nutrition, psychological support, which we all know is so important. That has been a national exemplar. We only had it on 2,000 patients. We want to roll it out to everybody across Greater Manchester. So my message is, if you have an idea, come to us as a Cancer Alliance. No bets, no ideas are off, no bets are off. We want to listen to you as a group of clinicians, managers, nurses, AHPs, whichever. And it isn't just the smart professors that we want to listen to. We want to listen to the nurses who are in clinic and going home to the husbands and saying, oh, if we just did this one thing in clinic, it makes such a difference. Please do come and speak to us and we can help, I hope, influence that. The patient's voice in all of this is so important. And I've never had cancer, so I cannot say what it feels like to be a cancer patient. And I may do because of the 1 in 2 statistic, but my husband had it, so I'm hoping I don't. But that's aside. Excuse the pun there, but I do. He does know I crack that joke every so often. But I don't know what it feels like to be a cancer patient. So you must listen to the cancer patients who are not just tokenism, not just the governor on the board at the hospital, so we've got patients involved. That's not patient involvement, and that's not a cancer patient's voice by any stretch of the imagination. At the Cancer Alliance, we have cancer patients, they're in the room today, and we have cancer patients on our board on every interview panel. They have told me, shut up, Claire, that's not the right thing to do, we need to do this, because they have walked through our services. So the voice of the cancer patient is paramount. Please make sure they are heard, because that's what we do as a Cancer Alliance. And you've heard today about breast cancer. The important part of breast cancer is the front end of the pathway. How that patient is referred in is so vital. That's why the brilliant work that the board has done on the new model of care for breast cancer, talking to primary care. It's not just about what happens in secondary care. Often there's pathways already well and truly advanced. So we need to look at our communities and what services we've got and our voluntary service organisations as well. And as I've talked there, you've got to empower you in the room. That's what the Cancer Alliance role is, for you to create the change that you need to in your pathways. Now, of course, we're exemplars in breast cancer, which you know. And there's a couple of things here that you know that we're leading on, which you were the first tumour to get stratified follow-up. And Sasha and others have talked about your overloaded clinics, the EPROMs, where there's too many patients coming through our services that could have a telephone conversation. We learnt that in COVID, or could have a text message. So there's the stratified follow-up is so important to help our very tired clinicians, and not just the oncologists across the system. We've talked about genomics, and we've talked about how we've had advanced in our genetic testing here in Greater Manchester. There's much more to do, our genomics and our genetic testing. And Anne talked about patients going for chemotherapy without all the tests. This just can't be right. So we are doing a big piece of work around pathology, which I'm supporting the Pathology Network to lead on around genetics as well. And these two bits around primary care are really important. So Joe Taylor, our patient here, who has done our red flag symptom, it's so important to educate GPs. And we can't just say it's really important to educate you. That's really condescending. If it was a GP in the room, I'd be feeling pretty peeved off. I don't need educating, but you do need reminding, and reminding through training and education. It's really, really important. And we have shifted the dial on the understanding around some of the endocrine therapies, secondary breast cancer, some of the key things that you've all talked about today here. And then finally, we talked about workforce. We can't grow GPs on trees or oncologists or all the rest of it. And we've got this new workforce, GPs with special interest, wanting to work across our cancer pathways. And at the moment, that as a innovation pilot that we're looking at looks very promising. So that's certainly a way forward for us. So I'm going to finish now. Thanks everybody for listening. I want your take-home messages to be, please listen to the voice of cancer patients, because you can't change services the people you are serving aren't listened to. If you have an idea and an innovation, or no, all bets are not off, please come to us, because we are here as a Cancer Alliance to listen to you. We can't fix every problem, but we represent you and the system. So please do come to us to talk about that. And most importantly, from my perspective, thanks to everybody who's doing such great work, because it's a particularly tough time at the moment in the NHS, and everybody's doing some marvellous work. So thank you. I'll just end on, this is our Cancer Alliance contact details. Claire Goldrick, who is rather marvellous, sat in the corner in a lovely sparkly top. We matched on our top today, didn't we? Is amazing. And a big thanks to Claire Garnsey, who has transformed the Breast Pathway Board with all of you along on the bus, the great bus of transforming breast cancer services. So you've done a marvellous job, and I really want to thank you on behalf of the Cancer Alliance as well. And look who's up next.
Are we all exhausted? Yes, okay. You'll be pleased to hear I have 2 slides and then it's home time. So we just wanted to finish off by bringing together sort of everything we've talked about today into what we are doing as the breast team at the Cancer Alliance. And those of you who sit on the board with me know about our plan on the page. So what we're doing is here on this fancy diagram. And you can see in the middle, in the grey, is all the things that the national team are asking us to do to prevent cancer, diagnose it earlier at an earlier stage, faster diagnosis, that yes or no within 28 days, deliver treatment within 62, and then support people to live better with breast cancer. So over in that top corner, that's all the stuff you heard today about the Mastalgia pathway that Ashu talked to us about. So it's about educating our primary care colleagues so that we refer in the right patients. A lot of the time, Mastalgia doesn't need to come into us. That's the work we did that reduced Mastalgia from 20% of our referrals to 8.5%. Backed up for those 8.5% that can't be reassured in primary care with our Mastalgia telephone clinic that Claire Robinson is leading on and Ashu talked to us about today. The next part is all the ETIP that you heard myself and Kate talk about today, which is the endocrine therapy improvement program of supporting patients to live better whilst on endocrine therapy. And both of those programs are supported by our little GPs there in the grey circles. So that's our GPER pilot. So our 6 GPs that are being piloted around the region, and we're hoping that we'll be able to extend that program because it really is working so wonderfully. You heard Suzanne talk today and Anne talk today about SAC delivery and all these new drugs and the huge pressure that is being put on our oncology colleagues and our breast care nurses who are trying to support those patients to deliver all these new SAC therapies. And my goodness, that is a mountain to climb. So the first step we made is Anne Armstrong is now co-leading the Pathway Board with me. So we've got that expert oncology voice and we're delighted to be working with Anne. We're so grateful for her support and collaboration. We're going to be looking at new workforce, ways to use the workforce, pathway efficiencies, and making sure we're using genomics to really streamline that pathway. And then what we haven't talked about today is about our radiology workforce. We did have a plan with the National Breast Imaging Academy, and because this is the first thing we came to actually a number of years ago, and great strides have been made. The National Breast Imaging Academy have done a wonderful job in terms of apprentice mammographers. They've done a great job, but we've come across a few barriers. And so we've had to rethink and pivot. And Gillian Hutchison, who's in the audience somewhere today, who's our radiology representative and also our programme director for the NHS breast screening programme in Manchester, and I are planning to reinvigorate this part of our plan. And we're really planning to focus on the next 12 months on advanced practice. So we want to support our advanced practitioners to be working right at the top of their skill set, improving their confidence and helping to take some of the workload from our consultant radiologists. And we'll continue to work in collaboration with the National Breast Imaging Academy. So my final slide is the things that I couldn't fit on my plan on the page. So as you heard Claire O'Rourke just talk about, what we're being asked by the national teams to diagnose more cancers earlier at stage 1 or 2. And I have to apologise a bit for this, because I was sort of sitting there giving ourselves a pat on the back because, you know, we're over that 75% mark. And I was thinking, well, maybe we don't need to deal with that. And I think I was very wrong, because what we don't know is what the inequities in the system are. So are there particular demographics of people, of women, who are being diagnosed at a later stage? Do we need to understand more about that? Does it mean that if you are a woman of, we don't know yet, but maybe of South Asian origin, if you are a woman of poor socioeconomic background, if you are a man, are you diagnosed at a later stage, and what are we doing about that? And just because we're over 75%, we are below the national average. We're at 81 instead of 86 as the national average. So we're going to start to look at that. So we're going to look at that data, try and work out what demographics mean that you're diagnosed at a later stage, and we're going to think about an action plan. We're absolutely delighted that that members of our wider workforce, Ashu Gandhi and Rajiv Dave, have been successful in obtaining an early diagnosis grant from the Cancer Alliance. And they're going to do a piece of research into inequalities in terms of accessing healthcare. So we do know that certain populations are presenting later, we think. We know they're perhaps not engaging well. And we use funny terms like hard to reach. I'm not sure how hard they are to reach. And what I don't think we know is why people aren't engaging. Who am I, as a middle-class, middle-aged white woman, to say why our South Asian population are not coming for screening? It's not okay to make assumptions. So we're going to be working with communities to work out why, not just the fact that some groups aren't engaging at an earlier time in the pathway, but why is that? So we're really, really excited about that piece of work, and really grateful to Ashu and Rajiv for leading on it. We're going to look at equity of access to all aspects of our personalised care. So Claire said earlier, we were the first to roll out PSFU, and that's great. Again, we pat ourselves on the back, but is that good enough as all the other tumour sites are catching us up? So we're really grateful, as I mentioned earlier, to have Claire Liu, who's our lead nurse at the Cancer Alliance for Breast. And I really encourage all of you, if you're a CNS or an allied health professional, to attend the Allied Health Professional Forum that we run for breast, because we really need your input into, are we offering the same PSFU around the region? Is it good enough? Are we missing anyone? And we really want to look at metastatic breast cancer, and the project we're hoping to look at is outcomes data. So we know that we don't know enough about metastatic breast cancer. Professor Horgan talked earlier about the National Metastatic Breast Cancer Audit. That's great. That might give us more information about how many people there are out there with metastatic breast cancer. But we're interested in knowing about outcomes as well. What does it mean to have metastatic breast cancer when you are diagnosed in 2024? You know, what does it mean if you get bone cancer? I don't think we have that information to be able to give patients correct information about what that means for them. What does your life look like over the next 2 years, or the next 10 years, or the next 15 years and beyond? So we're really excited about being able to get some data on that and to do something with it. And then finally, after this education event, what we're planning next year is we're going bigger. So we're going to do an event with our 2 other cancer alliances in the Northwest, so Cheshire and Mersey, and Lancs and South Cumbria. So we've started to make links with those alliances, and we know that they're doing things that we're not, and we're doing things that they're not. So next year we're going to have an event. There will be lots of education, but we're just working it out at the moment, but we're hoping it will be a workshop event where you can come and you can go to a workshop and go to the South and Lancs Cumbria team, and they will teach you how to do advice and guidance like they do. Give you a pack so you can take it home and implement it easily in your own unit. So we're also really excited about that. So please look out for all of these things. This is just about getting involved. I think Claire said very clearly, we want this to be a regional work. We want you all to get involved, so please don't hesitate to contact us. So before I let you go home, just bear with me for about 2 minutes. I just wanted to let you know a few little things. First of all the slides and recordings will be available to view on demand. We'll let the Academy team have the weekend off, but I'm hoping that they'll be online on the Cancer Academy website next week. We would be really grateful if you fill out the evaluation form when it's shared round so we can take on your feedback for future events. Don't take your badges home. We want to be able to reuse them, so please just take them off, pop them on the desk, and we will recycle and reuse those for you. If you've got any questions at all, please don't hesitate to contact us, and particularly you can also contact Claire Goldrick. You could just stand up, Claire. So those of you who don't know Claire, Claire is absolutely my right-hand woman. Nothing would happen for Breast in the Cancer Alliance without Claire. She's an absolute superstar. So please do not hesitate to contact Claire if you've got any comments about what we've discussed today. Massive thank you to all of our speakers, especially Sophie Green and Professor Stein for travelling to the event, and for Amelia, our service user representative, who shared her experience of risk-reducing endocrine therapy. Thank you to all the chairs, Nicola, Vivek, Claire and Claire. And that didn't include me or Claire Goldrick. Doesn't say much for diversity, does it? But also thank you to the GM Cancer Academy for their support in delivering the day, especially Tilly and Ellen. We have a little something for you, but just before we give you your booze and you run off, we just want to thank our sponsors as well: AstraZeneca, Roche, Novartis, Exact Sciences, Pfizer and Lilly. But I would like to close by giving a round of applause to Ellen over there, Tilly, who's over here from the Cancer Academy, who've organised this day, and a huge thank you to Claire Goldrick, who has absolutely choreographed this day from start to finish. So thank you all. So thank you all for coming. I'm sorry I didn't buy you all a bottle of booze. Please go home and buy your own wine. Thank you.